Hi, my name is Daniela and I am studying a Bachelor of Medical Science specialising in the field of pathology. With that being said, my chosen topic under investigation is personalised medicines for the treatment of translocation-driven cancers, but more specifically, potential molecular targets for the diagnosis and treatment of Ewing sarcoma. The effects associated with typical cancer treatments, such as chemotherapy and radiation therapy, have harsh side effects such as infertility, drug resistance, limb dysfunction and amputation, as well as severe infections due to being immunocompromised. As a result, the innovation and establishment of new therapeutic approaches is required in an attempt to cure this rare and aggressive cancer, but also maintain the quality of life in patients and survivors. This presentation serves as an overview and evaluation of several potential molecular strategies that may serve as therapeutic targets for the treatment of Ewing sarcoma. These include the blockade of the translocation itself, EWS-FLI1, caveolin-1, heat shock protein 90, insulin-like growth factor receptor 1, vascular endothelial growth factor A, and small interfering RNA. Ewing sarcoma was first described in 1921 by American pathologist James Ewing and belongs to the Ewing sarcoma family of tumours. While a relatively rare cancer, Ewing sarcoma is actually the second most malignant bone neoplasm after osteosarcoma. It is extremely aggressive and arises from mesenchymal tissue, often beginning in soft tissue and long bones, such as those of the arms and legs, as well as the pelvic bones. It has great potential to quickly metastasize to the lungs and bone marrow, appearing as small, undifferentiated blue round cells, as evident in this image here. These tumours are predominantly diagnosed in children and adolescents up to 20 years and have slight male and Caucasian predominance. Many researchers have defined Ewing sarcoma by this chimeric chromosomal translocation. This means that the translocation has occurred on the long arm of chromosome 11 at band 22 and the short arm of chromosome 24 at band 12. The result of this translocation causes a gene fusion between the EWSRI locus and an ETS transcription factor gene that encodes for an oncogenic aberrant transcription factor with several downstream targets contributing to tumorigenesis. The translocation EWS-FLI1 confers a highly malignant phenotype and accounts for approximately 85% of Ewing sarcoma cases. On the other hand, EWS-ERG is the rarer translocation of the two, representing itself in only 5 to 10% of Ewing sarcoma cases. Characteristic signs and symptoms of Ewing sarcoma include pain, tenderness, and swelling around the affected site that usually presents as a lump. In addition, fever is common and bones are often fragile, effortlessly fracturing and breaking. After physical examination, MRIs, CTs, and PETs are conducted and interpreted to form a preliminary diagnosis. A biopsy of the area and blood investigations are also conducted to further confirm the diagnosis and decipher a treatment plan and prognosis. Immunohistochemistry and cytogenetic investigations, such as reverse transcription polymerase chain reaction, are particularly important in the diagnosis of Ewing sarcoma as they identify the malignant cells and confirm the genetic fusions that characterize different malignancies. With the application of traditional cancer therapies such as chemotherapy, radiation therapy, and surgery, the survival rate is 60% for those with only primary tumours. The overall prognosis is poor for metastatic sufferers with a survival rate of only 20%, with patients typically dying within 5 years of diagnosis. Since Ewing sarcoma is highly aggressive, Metastasis is a critical issue associated with up to 85% of cases metastasizing, 20% of which are already metastatic at diagnosis. Standard treatments for Ewing sarcoma, both localized and metastatic cases, include multimodal therapies such as chemotherapy, radiation therapy, and surgery, like I've stated previously. In metastatic cases, combination chemotherapy is usually given as the treatment of choice, as well as high-dose chemotherapy and stem cell transplants. With this being said, obviously treatments differ from case to case depending on different factors. These include the general health of the patient, at what stage the malignancy was diagnosed, where the tumour is located, whether it has metastasized, how big the tumour is, and whether it can be excised, and most importantly, how the treatment will affect overall systemic functions and health of the patient. So, as I said previously, up to 85% of sufferers present with the EWS-FLI1 translocation, so that's the most common one. So, it seems logical that directly targeting this translocation could serve as a potential therapy. And according to studies, inhibiting this chimeric gene fusion can be achieved by targeting lysine-specific demethylase 1, or in shorthand, LSD1. It is overexpressed not only in Ewing sarcoma, but in many other cancers such as breast, lung, colon, prostate, gastric, and also acute myeloid leukemia. It has a primary role in cell proliferation, cell migration, and metastasis. With this being said, Ewing sarcoma patient samples and preclinical data have suggested that inhibiting LSD1 disrupts the function of the gene fusion and ultimately intercepts the oncogenic pathway. When this theory was conducted in vitro, the downregulation of LSD1 expression resulted in significantly reduced tumour cell proliferation and ultimately prevented metastasis. Although LSD1 inhibitor tranicyclopramine showed a positive impact in vitro and preclinical studies, no appropriate candidates have yet been found in order for this therapeutic strategy to progress to clinical trials. The next molecular target is caveolin-1, also known as CAV1. It is an integral membrane protein that simply forms plasma membrane invaginations, which regulate several intracellular signaling pathways. CAV1 is expressed in many organs such as the heart, esophagus, spleen, uterus, and lung, as well as adipose and smooth muscle tissue. With this being said, CAV1 is identified as a metastasis-associated gene, as well as a transcriptional target of EWS-FLI1, so the common translocation. It also plays a pivotal role in cancer processes such as cellular transformation, tumorigenesis, cell death and survival, drug resistance, and angiogenesis. Its expression has been implicated in other malignancies in addition to Ewing sarcoma, and these include pancreatic cancer, prostate cancer, lung cancer, brain cancer, and invasive breast carcinoma. Research has proven that increased CAV1 levels are also associated with tumour development and metastatic progression. In vitro studies in mice demonstrated that the suppression of CAV1 downregulates the malignant phenotype of Ewing sarcoma cells and ultimately decreases the potential for tumorigenesis and metastasis. Researchers have also determined that invasive capabilities of CAV1 in the Ewing sarcoma family of tumours, hypothesizing that CAV1 modulates the metastatic ability of cells. Clinical studies have concluded that upregulation of CAV1 is directly proportional to metastasis and poor prognosis, not only in Ewing sarcoma, but in several of the cancers I just mentioned. In saying this, it has been established that the downregulation of CAV1 correlates significantly with the reduction in invasiveness of tumour cells, showing great potential to become a molecular target for the treatment of Ewing sarcoma and potentially many other cancers that express high levels of CAV1. So heat shock proteins, they are key molecules that are involved in responses to stress. Heat shock protein 90 is required to maintain the stability and function of activated and expressed signaling proteins, as well as multiple mutated, chimeric, or overexpressed signaling proteins that promote cancer. It is also involved in apoptosis regulation, cell growth regulation, and anti-cancer drug resistance. Correlations have been made between elevated heat shock protein levels and cancer progression. These were established in both in vitro and in vivo studies. And heat shock protein 90 inhibitors showed potential to be a molecular treatment as they have expressed many anti-tumor properties in preclinical models as they interacted with oncogenic proteins, causing inactivation, destabilization, and degradation of these proteins. Currently, heat shock protein 90 inhibitor geldenomycin shows positive perspective, reaching phase 1 of clinical trials. In addition, it has been hypothesized that heat shock protein 90 expression could be a predictive factor of a patient's response to insulin-like growth factor receptor 1 targeting therapies. A new therapy also currently undergoing clinical trials, and we will also discuss this in the slides to come. In vitro studies have also established that combining heat shock protein 90 inhibitors proves to reduce tumor cell growth even further when it's combined with insulin-like growth factor receptor 1 targeting therapies. So that brings us to insulin-like growth factor receptor 1. This factor plays a positive role in the human body with key functions in embryogenesis and early development. Much evidence indicates that insulin-like growth factor is also a key factor in tumor genesis through interaction of its cell surface receptors, in particular receptor 1. The presence of this receptor has been observed in deregulated autocrine loops in Ewing sarcoma and is thought to contribute to pathogenesis and the progression of this malignancy. Therefore, blocking this receptor shows great potential to become a modern target for the treatment of Ewing sarcoma. The interaction between the fusion gene EWS-FLI1 and insulin-like growth factor receptor 1 have been observed through in vivo studies in mice. Results revealed that the promotion of insulin-like growth factor 1 receptor encouraged potential binding sites for several oncogenic transcription factors, confirming the hypothesis that Ewing sarcoma fusion genes have direct interaction with the receptor promoter, encouraging the onset and progression of this disease. The good news is, currently there are approximately 25 potential therapeutic agents that act through inhibiting receptor 1. 62-MUMBUB is an immunoglobulin G1 monoclonal antibody that specifically targets insulin-like growth factor receptor 1. It has high affinity, hindering the oncogenic pathway and ultimately prohibits the growth of various tumor cell lines. This monoclonal antibody has also proven to be a less toxic therapy with higher patient acceptance in Ewing sarcoma sufferers, allowing for it to successfully progress through to the next stages of clinical trials. Vascular endothelial growth factor A, or in short VEGF-A, is also important for the growth of cancers, allowing survival of cells by inducing vascular formation and maintaining angiogenesis. Like CAV1 and heat shock protein 90, vascular endothelial growth factor A is also overexpressed, approximately 3 times more in malignant Ewing sarcoma cells than in that of normal cells. Transecting the E1A gene reduces the expression of vascular endothelial growth factor A, which consequently reduces the tumour vessel density in vivo, suggesting that E1A gene transfer exhibits anti-angiogenic effects in Ewing sarcoma and possibly other cancer types. Furthermore, tumour suppression was also evident as a result of its apoptotic capabilities, ultimately expanding the survival rates in treated mice. Fortunately, clinical trials have proven that E1A therapy acts positively in suppressing tumour growth in patients suffering from breast, ovarian, and neck cancer. However, it is yet to be implemented in an Ewing sarcoma candidate. Lastly, antisense, also known as small interfering RNA, is a highly specific and powerful therapeutic tool that aims to safely target and silence aberrant gene expression, such as that defined in Ewing sarcoma. This technique proposes the use of oligodeoxynucleotides that target the translocation in RNA in hope of reducing gene expression and consequently inhibiting the proliferation of Ewing sarcoma cell lines. Researchers have tested the therapeutic potential of small interfering RNA on the Ewing sarcoma oncogene using the same protocol applied in HIV therapies. Results prove that blocking the gene fusion successfully halted cellular proliferation by preventing activation of the translocation and ultimately altering the phenotype as a result of expressing anti-EWS FLI1 instead. It has also been affirmed that while this therapy may not actually cure Ewing sarcoma, it maintains residual disease at a low level by preventing cell proliferation and minimizing the opportunity for metastasis and progression, which ultimately prolongs survival rates in sufferers. So, despite the application of harsh chemotherapy and radiation techniques, survivors typically have a poor standard of living from the associated side effects and still have a high chance of malignant recurrence. This presentation has provided and discussed many potential molecular targets that show promising capabilities for the treatment of Ewing sarcoma. Although additional investigations and clinical trials are required before any of these therapies can be applied in the clinical environment, they have provided a foundation to build upon and most importantly, they have provided hope for a successful cure for those suffering from this rare and aggressive cancer. That concludes my presentation. Here are my image references. And if you could please refer to the reference list in the literature review, that would be great. Thank you.